Welcome to this explainer where we're going to decode the median nerve for your NEET PG and MBBS exams. Ekdam high yield focus rahega, so let's get right into it.
Let's start with a clinical mystery. Imagine a patient comes into the casualty और उनका हाथ एक अजीब position में है. Why exactly does damage to this specific nerve create the famous hand of benediction deformity? क्या anatomically गलत हुआ है? Well, by the end of this explainer, you're going to know exactly why. आज हम cover करेंगे this exact roadmap. Roots and intro, its course in the arm, the forearm breakdown, palm and loaf muscles, and finally, the clinical deformities. Okay, Section 1, Roots and Introduction. Let's dive right into the origin story of our nerve. So it's famously known as the labrador's nerve. Kyun? Because it literally powers the coarse, heavy lifting movements of the forearm. And note that it takes contributions from all the roots of the brachial plexus. We're talking C5, C6, C7, C8, or T1. Pura mix hai. Now look at this. Notice how the lateral root and medial root of the median nerve fuse together. But किसके ऊपर fuse हो रहे हैं? Right over the brachial artery to form the main trunk. ये relation बहुत ही important है आपके MCQs के लिए, so keep it in mind. Moving to Section 2, let's track its course through the arm and the cubital fossa. अब इसको ध्यान से समझना, because the relation to the brachial artery actually flips halfway down the arm. Upper part में brachial artery medial होती है, but in the middle arm, the median nerve crosses the artery from the lateral to the medial side. ये crossing एक classic surgical landmark है. और फिर it enters straight into the anterior part of the elbow joint at the cubital fossa. For your exams, just remember the golden mnemonic, MBBS. Cubital fossa के contents strictly from medial to lateral side. Median nerve, brachial artery, biceps tendon, or superficial branch of radial nerve. MBBS. Super easy to remember, right? Looking closely at this view of the cubital fossa, the median nerve sits most medially, nestled right between the pronator teres medially and the brachioradialis laterally. Next time you're dissecting, सबसे medial structure आपको median nerve ही मिलेगा. Moving on to Section 3, the forearm breakdown. It enters the forearm by passing exactly between the two heads of the pronator teres. I've set this up for quick recall. Notice how the median nerve handles almost the entire superficial layer. Pronator teres, flexor carpi radialis, palmaris longus, and URFDS. Surf FCU and RFDP का medial half ulnar nerve का दे दिया गया है. So basically, बाकी forearm flexors का main boss अपना median nerve ही है. Now, this right here is a very high-yield NEET PG point. The deep muscles like the flexor pollicis longus or lateral half of the flexor digitorum profundus are specifically supplied by its major branch, the anterior interosseous nerve, or the AIN. Check out this dissection! Tracing from the common origin at the medial epicondyle, watch how the AIN dives deep. It runs right along the interosseous membrane to supply those deep flexors. Our finally pronator quadratus तक पहुंच दी है. All right, Section 4, palm entry and the LOF muscles. Let's watch the median nerve cross the wrist and enter the palm. So it dives safely under the flexor retinaculum, जिसको हम transverse carpal ligament भी बोलते हैं. It gives off a recurrent motor branch and supplies those loaf muscles. But doctors, never ever forget that the tiny palmar cutaneous branch travels above the retinaculum. ये एक छोटी सी detail है, but it completely changes your clinical scenarios as we'll see in a minute. Inside the palm, the recurrent branch supplies the thenar eminence, which is easily memorized by the loaf mnemonic. L for lumbricals 1 and 2, O for opponens pollices, A for abductor pollices brevis, and F for flexor pollices brevis. Beyond the loaf muscles that form that bulky thenar eminence, map out the sensory territory here. The median nerve owns the lateral 3.5 digits on the palmar side. Matlab thumb, index, middle, और ring finger का आधा हिस्सा, plus उनके dorsal tips भी. Okay, Section 5, key clinical deformities. Let's tie all this anatomy directly to the clinical words. Look at these presentations. If the AIN is injured proximally, you lose flexion in the index and middle fingers क्योंकि lateral FDP और FPL काम नहीं कर रहे. So जब patient मुट्ठी बंद करने की कोशिश करेगा, they literally can't flex those two fingers, causing this exact hand of benediction. On the flip side, palsy of the opponent's pollicis gives you the flat ape thumb deformity, जहां thenar eminence की atrophy हो जाती है. Now, the absolutely crucial point is comparing these two, carpal tunnel syndrome versus a wrist/injury. Because the palmar cutaneous branch travels above the carpal tunnel, thinner sensation is spared in carpal tunnel syndrome. But in a superficial wrist slash, वो palmar branch कट जाती है. So sensation in the thenar eminence is totally lost. Difference समझ आया? It's all about the anatomy of that retinaculum. So let's wrap up with a question. If a patient presents with an ape thumb, but totally normal sensation over their thenar eminence, what exact space should you image first? Think about it, doctors. Apply the anatomy we just built today. Ape thumb means the recurrent branch is affected, but normal sensation means the palmar cutaneous branch is totally safe. So the lesion absolutely has to be inside the carpal tunnel. Keep revising this logic, keep studying, and you are going to ace your MCQs for sure. See you in the next explainer.